Welcome to Leveling Up Primary Biliary Cholangitis, Optimizing Biomarker Surveillance, Addressing PBC-Related Pruritus, and Application of Real-World Evidence. My name is Dr. Atusa Rabi. I'm joined today by two of my colleagues, Dr. Hannah Blaney, MD, MPH, Transplant Pathology Fellow from MedStar Health, Georgetown University, as well as Dr. Anahita Rabi, MD, MHS, who's a transplant hepatology from Digestive Disease Section, Yale School of Medicine. For full relevant financial disclosure information, please see the iridium.com landing page for this activity. This is supported by an independent educational grant from Intercept Pharmaceutical. We would like to thank them for their support for this initiative. The learning objective for today's program are describe factors contributing to low initiation rates of PBC therapy and strategies to address barriers to specialty care. So we realize that it's crucial to differentiate between PBC and other conditions that can present with similar symptoms, specifically conditions that present with cholestasis. This could be extrahepatic, such as malignancy, stones, or intrahepatics, like autoimmune disease, alcohol-related liver disease, drug-induced liver injury, or primary sclerosing cholangitis. Can you tell us a little bit about how best to distinguish PBC from these conditions?
Yes, so PBC is fairly straightforward to diagnose, but we do have to differentiate it from other liver disease that may present similarly. This differentiation can be done with a combination of labs and imaging. The serologic hallmark of PBC is anti-mitochondrial antibody, or AMA positivity. So first, we must consider a diagnosis of extrahepatic cholestasis, including conditions like cholelithiasis, malignancy, or inflammatory stenosis. Typically, this can be done with imaging, including abdominal ultrasound, with evidence of biliary dilation, stones, or masses confirming extrahepatic cholestasis. If an inflammatory stenosis is suspected, the clinician could consider IgG4-mediated strictures, which can be assessed with serum IgG4. Conditions causing intrahepatic cholestasis should also be considered. PBC can be differentiated from intrahepatic cholestasis through solid history, labs, and then further imaging. So autoimmune hepatitis typically has a more hepatocellular pattern of injury, with patients often having an elevated serum IgG and positive anti-smooth muscle antibodies. Alcohol-associated liver disease can present with a mixed pattern of liver injury, with a history and serology playing a key role here in the differentiation. Drug-induced liver injury should be assessed with a careful review of all recent medications and over-the-counter supplements. In patients with an unclear diagnosis, it may be worthwhile to trend liver enzymes with expected improvement with the withdrawal of the offending medication. Primary sclerosing cholangitis can be differentiated with serology and imaging, with a positive AMA supported of PBC and large duct stricturing on MRCP more consistent with PSC.
So now let's shift our focus to comparing the traditional paradigm in treatment of PBC as well as new treatment paradigms. Can you walk us through both paradigms and also touch on the importance of multidisciplinary care in managing PBC complications?
Absolutely. The current paradigm is once you diagnose PBC, you start the patients on UDCA and you'll monitor, and basically to determine if someone is responding to treatment or not, you'll give them a full year. And then at the end of the year, if they're not meeting the response criteria, then you kind of think about starting second line treatment options and obviously managing symptoms down the line. However, the new paradigm is more of a personalized care. So once you diagnose the patient, you want to look at it as kind of a whole and see what is their overall risk, how much liver fibrosis there is, what is their risk of progression, what are the symptoms they currently have. And then you start kind of modifying your treatment and mainly evaluation for a response to treatment differently if a patient is very high risk for progression. And, you try to address symptoms, quality of life, and other things kind of at the same time rather than just waiting for that laboratory values at 1 year to decide if someone is responding or not. And in terms of the kind of multidisciplinary team approach, PBC has systemic complications. So patients can have osteoporosis, osteopenia, high risk for dental infections. They can have vitamin deficiencies, specifically with fat-soluble vitamins, or hyperlipidemia. So, it is not just a disease that only affects the liver. So to be able to kind of manage all of these systemic complications, you need a multidisciplinary team consisting of primary care physicians, endocrinologists, dentists, obviously gastroenterologists or hepatologists, and dietitians. So through that, you hopefully are able to provide a more comprehensive care for these patients.
So if I may summarize the current treatment landscape for PBC, as well as some potential new drugs on the horizon, we know that UDCA is our first line of therapy approved. However, up to 40% of patients with PBC are unresponsive. Obetacolic acid was FDA approved in 2016 based on phase 3 POISE trial, which recruited 216 patients. The primary endpoint for this trial was a combination of reaching a serum level of alkaline phosphatase less than 1.67 times upper limit normal, with a reduction from baseline greater than 15%, as well as patients with normal bilirubin. 50% of patients treated with obetacolic acid met response criteria when followed at months 48, 60, and 72, which supported sustained response. L-epipneuronal was just recently approved this year in June. It's a PPAR alpha delta agonist. This was, as I said, very recently approved based on a phase 3 Elevate trial, which recruited 161 patients. The primary endpoint, again, combination of reaching a serum level alkaline phosphatase less than 1.67 times upper limit normal, with a reduction from baseline greater than 15% and with normal bilirubin. And in this trial, 51% of patients treated with L-epipneuronal met a response criteria at week 52. There's also fibrates that can be used second-line therapy. They're off-label. And then there are other PBC treatment in phase 3 clinical trials, such as PPAR delta agonists, seladelpar. Now, I would like to transition from theory to practice. We'll try to apply all the data and strategies that we have discussed into real-world context, discussing a patient. This will help us see how the principles of personalized care and timely advancement to second-line treatment can actually directly impact patient outcomes in PBC management. So I want to now discuss a very specific patient with you. This is hypothetical patient, meet Sally. She's 55 years old. She has a history of PBC, and she has been on UDCA for 5 years. She comes to you to establish care, and her alkaline phosphatase on routine check is 220. So based on what we discussed, how would you approach this, Anaita?
So basically, with the alk phos being at 200, there's concern that this patient is not responding to treatment. Although I would want to know how long the patient has not been responding to treatment. Is it just like a recent thing, or has been on the medication not responding for 5 years now? But basically, once you see a non-response, especially in someone who has been on this medication for a long time, you want to consider switching to second-line agents. And it's also important to get a sense of, does she have advanced fibrosis, which, you would get that from a transient elastography or getting an MR elastography. And if advanced fibrosis is actually present, are we talking about clinically significant portal hypertension or not? And then lastly, obviously, having any decompensation. So apart from having advanced fibrosis or having CSPH or clinical decompensations, if the UDCA is not working for the patient, then we're thinking about second-line treatments. And obetacolic acid, again, can be started at 5 milligram daily, and then see if the patient is tolerant. We can increase it to 10 milligram over the next 3 months or so. Or you can consider off-label use of fenofibrate, again, starting at about 45 milligram per day, and then titrating it up based on tolerance. You want to, again, reassess in about 3 to 6 months based on the alkaline phosphatase and bilirubin levels to make sure that the patient is responding to the second line. And if the patient doesn't respond to the second line, then you could potentially switch to second line agent or even consider referral for randomized trials or consider a triple therapy situation.
And I think that's a very good point, that just because medication has been prescribed or as part of the medication list doesn't mean that the patient has been actually taking them. So that's important to confirm compliance. And it's important to make sure that the dose is appropriate for patient's weight. So those are key points to consider. So in summary, if I may, primary biliary cholangitis is a progressive autoimmune liver disease, as Anahita described, is linked to genetic, epigenetic, environmental factors, but the diagnosis is usually established with elevation of liver enzymes as well as presence of anti-mitochondrial antibodies. Despite having criteria for diagnosis, challenges remain with poor adherence to management guidelines, limited physician awareness, and insufficient patient education, which all in all can actually impact clinical outcomes. The updated treatment paradigm emphasizes more of a personalized care to enhance patient outcomes. It is important that for those patients who do not respond or do not tolerate the first line, they would be transitioned to Obetacolic acid as a second line therapy. And at this point, we have reached the end of this episode. I want to thank all of my colleagues for this engaging discussion. We would also like to thank you, Intercept, for their support of this program. You can claim your CME credit by filling out the evaluation and post test. And also make sure to follow Iridium on X, Facebook, LinkedIn to see the corresponding MedEd threads.